The first video on the menstrual cycle dealt with the different organs involved with the normal cycle. We learned that the hypothalamus, pituitary, the ovaries, and the uterus, they all act in harmony to ensure that the cycle stays as it is on a month-to-month basis. But there are different abnormalities in a normal menstrual cycle, and any physician would know that women would often present with varied symptoms, and sometimes it gets really confusing and it gets a bit difficult to diagnose. But what we are going to learn today is an easier way, an easier method to how to approach a patient who comes with menstrual irregularity, and the quickest way to reach a possible diagnosis. So what we learned was that the normal menstrual cycle is for 28 days plus minus 7 days. So that means from 21 to 35 days is a normal menstrual cycle. The average cycle lasts for about 3 to 5 days. It can be less than that. It can be 2 days. It can be 6 days, and they're both considered to be normal. The average blood loss in one cycle is 30 to 50 ml, and that is per cycle, not per day. A lot of the time, this is confused with the thought that probably it's 30 to 50 ml per day, but no, indeed, it's 30 to 50 ml per cycle. That means for the whole length, that is 3 to 5 days. A blood loss of greater than 100 ml in one cycle, and if that carries on for 3 cycles, will lead to iron deficiency and hence anemia. So what we also learned was that there are 4 organs which are involved with the normal menstrual cycle, and these are the hypothalamus. I'm going to mark that as 1, the pituitary gland, which releases FSH and LH, as 2, the ovary as 3, and the uterus as 4. And they all act in synchrony to produce a normal menstrual cycle. But essentially, it falls down to 2 hormones, estrogen and progesterone. And I'll come to that in a minute, why these 2 are so important in different variations of a normal cycle. So the variations include amenorrhea. Amenorrhea means absence of menses. And amenorrhea is of 2 types. One is primary and the other one is secondary. Primary means that the woman never had periods. Never had periods. So that's primary amenorrhea. Secondary means that the woman had periods from before, but the periods have stopped now, and we have to find out why they have stopped. So if she never had any periods from day 1, the problem is either number 3, that means ovarian failure. There is an ovarian failure to begin with, or this can be number 4, and that means there is an absence of uterus. That's number 4. And then it could be number 2, meaning thereby that there could be something wrong with the pituitary gland. It's unlikely that a hypothalamic cause is going to cause primary amenorrhea. So if there is primary amenorrhea, either there is something wrong with the ovary, there is something wrong with the uterus, there's absence of uterus, or there is a pituitary problem. If there is secondary amenorrhea, the most important thing to rule out is pregnancy. So that means the problem is number 4. I shouldn't call it a problem, but the cause can be in the in the uterus. So the uterus comes as number one for secondary amenorrhea. Then is number three. That means there is an ovarian cause, and that means that there is probably secondary ovarian failure. This could be due to drugs, medications. It can be because of cancers. It can be because of radiotherapy. It can be autoimmune in nature. So there is an ovarian cause, and then unlikely one, but nevertheless can be there, is number two. That means a pituitary cause. But here we also have the hypothalamic cause as well. And the reason why we say that there is a hypothalamic cause is because it could be because of certain medications, for instance, antidepressants, antipsychotics. It can be because of radiotherapy, it can be because of a tumor, and likewise, it can be the pituitary could be affected by means of a tumor. So, in secondary amenorrhea, you can have a problem in all four areas, but basically there is a problem here. Number four comes at the top, and then followed by number three. That means there's ovarian failure, followed by the pituitary gland, and then we come to the hypothalamus. The other variants of menstruation are menorrhagia. Menorrhagia means excessive blood loss. Excessive blood loss or increased cycle duration. So the cycle is greater than 5 days, 7 days, whatever, or there is excessive blood loss. As we see that the average blood loss in a cycle is 30 to 50 ml. And if it's this much, this would obviously be regarded as menorrhagia. And this can lead on to iron deficiency, and that's how a lot of people, a lot of women present, and they often present with anemia and feature symptoms of anemia because they've got menorrhagia and they lose excessive blood per cycle, or the cycle length is long, and so therefore the cumulative blood loss reaches that one. So it could actually be that, but plus because the extension, so therefore the blood loss is great. Menorrhagia, for all practical purposes, has got everything to do with estrogen and progesterone. Estrogen and progesterone are involved with the development of the endometrial lining of the uterus in preparation for pregnancy. And so therefore, when you lose excessive amount of blood, that means that the endometrial thickening was there, and the endometrial thickening was there for a reason, because you had excessive amounts of estrogen and or progesterone. Both of them are released by the ovary. So menorrhagia, for all practical purposes, means that you have to rule out a problem with the ovary first of all. What kind of a problem with the ovary? The commonest one is an adnexal cyst. So adnexal cyst is the commoner one, which continues to release lots and lots of progesterone, and progesterone, we know, is the hormone which comes in the latter part, in the second part, which is the luteal phase of the menstrual cycle, and that is involved with the growth of the endometrium, and thereby ultimately shedding of the endometrium when the progesterone levels drop. The second cause for menorrhagia, that is excessive blood loss, is going to be number four. And that is that the uterus, although it is under command from the ovarian hormones, the uterus actually becomes independent. And how does it become independent? And that's by two ways. Number one, there is endometriosis, and endometriosis, we know, is something in which there is excessive proliferation of the endometrium, and when the endometrium grows too much, it can become independent. It's called as adenomyosis. We know that endometriosis can also behave as a systemic illness as well, because it can disperse into the body via the fallopian tubes. So either there is endometriosis or there is a myoma. I'm not talking about cancers, because menorrhagia, I'll just come to that in a minute, because menorrhagia, for all practical purposes, may or may not mean, but menorrhagia means that there is endometrial proliferation. So what do the myomas do? If the myoma is here, a big myoma, a lot of women will have smaller myomas, and that's perfectly normal, and it's just an incidental finding. It doesn't do anything to them. But if the myoma is a large one, it prevents the uterus to contract. and to contract to come back to its normal premenstrual size. And when it fails to contract, the bleeding it continues. And sometimes the myoma is actually a low-lying myoma, which is just at the cervix, and therefore it prevents the cervix to close. In both of these situations, the myomas can cause excessive bleedings and can cause menorrhagia. Apart from these two, any other cause for menorrhagia is pretty uncommon, and these are the two commonest ones in which we get menorrhagia. Uh, then we get another term, and that is called as hypomenorrhea. Hypomenorrhea is indeed the opposite of menorrhagia. In hypomenorrhea, there is less blood loss. The cycle length is normal, 3 to 5 days, but the blood loss is less during the cycle. And so hypomenorrhea, as I said, is the opposite of that one. And what that means is if somebody's got hypomenorrhea, they've got reduced levels of estrogen and progesterone. You get excessive levels of estrogen and progesterone, you get menorrhagia, you get reduced levels of estrogen and progesterone, you get hypomenorrhea. And if that is the case, then obviously the problem lies with the ovary. That means number 3. It's unlikely that hypomenorrhea is because of number 4, because number 4, that is the uterus, is under the command of the ovary. The uterus on its own does not have anything to do with that, with the periods, because it's the estrogen which comes. It's the progesterone with the driving forces. Hypomenorrhea can be a feature of hypopituitarism. So yes, number 2 also comes. For instance, somebody has got pituitary dependent hormonal problems. They've got prolactinoma, they've got a pituitary tumor, for instance, they've got growth hormone producing pituitary tumor, then yes, we can get that. Or they actually have like something like pituitary apoplexy, something happened, and that can cause hypomenorrhea. But in severe cases of pituitary disease, you won't get hypomenorrhea, you're likely to get amenorrhea because the driving force it goes away. Hypomenorrhea sometimes can also occur with the hypothalamic, although it's not common. The other thing to remember in hypomenorrhea is that apart from there being a deficiency of estrogen progesterone, the other cause is nutritional. So always rule out a nutritional deficiency in any woman who comes with hypomenorrhea. And that commonly is, for instance, there is iron deficiency. So there's iron deficiency, the uterus wall will not grow, and obviously the body is going to be starved of iron and all the essential elements, and so therefore you will expect hypomenorrhea as well. The third condition is oligomenorrhea. Oligomenorrhea basically means that the cycles do not come in a sequential fashion, like they don't come every month. So there may be a cycle in January, none in February, none in March, but you can get one in April, and then May and June, and perhaps something like that. So they come intermittently. The cycle length may be 3 to 5 days. There may not be any spotting. It is associated with menorrhagia or hypomenorrhea, but oligomenorrhea practically means that the cycles are now fading away. And when you get a picture of cycles fading away, it's almost always an ovarian cause. That means the ovaries are failing. A point to consider always is that abnormalities in menstruation means that one of these 4 have failed to perform. They have failed to perform their duty. So you can call them as hypothalamic failure, you can call it as a pituitary failure, you can call it as a uterine or an ovarian failure, and it will be a lot easier to remember. Oligomenorrhea inadvertently means that the ovaries are failing. Nothing to do with the uterus. It's got nothing to do with the hypothalamus, nothing to do with the pituitary. The only thing that may be of relevance when the pituitary or the hypothalamus comes, and that is by drugs. Antipsychotic drugs, you've got antidepressants, sleeping tablets, different kinds of drugs, weight loss drugs, different kinds of drugs. So medications can cause any of these problems. The last one is metromenoria, also called as metrorrhagia. Metromenoria is perhaps the most commonest of all. So metromenoria and menorrhagia are the commonest one. Metromenoria means that there is intermittent spotting. So say for instance, the period started on day one, they lasted till day three, or say for example, the first of the month till the third, and then you had an absence of periods, and then they started again from day 10 to day 12. So they're intermittent from day 20 to 22. So then they're intermittent, and so therefore this obviously is a nuisance, a huge cause of distress for the woman, because she doesn't know if the periods have stopped or not, and then she'll obviously have to be on guard. She'll find it very difficult to socialize or to go to work, because she'll always be on guard because of that. So metromenoria means that they come intermittently, also called as spotting. A lot of women will come and say that they're spotting intermittently during the whole month. Metromenoria again has got everything to do with the ovary, and then metromenoria is caused by the hypothalamus. So the ovary and hypothalamus. Unlikely that the uterine problem is going to cause metromenoria. It's unlikely that the pituitary cause is going to cause metromenoria. It's usually the ovary, and it's usually the hypothalamus. Why the hypothalamus? Once again, yes, you guessed it, drugs, medication. The woman may be taking several kinds of different medications. For example, medication for rheumatoid arthritis, medications for cancers, different kinds of medications. So if she comes with spotting, either the ovary is giving up, or she's under the influence of certain drugs. Apart from these 1, 2, 3, 4, and 5, you can get different combinations of these as well. And the combinations will be, for instance, you can get oligo oligomenorrhagia. Oligomenorrhagia means she had her period in January and they were heavy. And then there was a pause of 2, 3 months, and then she had her periods in May and they were heavy. Menorrhagia means heavy. For all practical purposes, this means that there is an ovarian cause. The ovaries are intermittently releasing estrogen and progesterone. Or with oligomenorrhea, the woman was previously on a pill, oral contraceptive pill, and then she stopped the oral contraceptive pill, and the body hasn't regained the normal cyclical fashion. So these are the two causes. So once again, as I said, so there is a drug, medications, and there is the ovary causing oligomenorrhagia. Likewise, you can also have hypometrorrhagia or hypometromenoria. Hypo means less blood and intermittently. So if there is intermittently less bleeding, that means spotting, but there is very, very, very thin spotting, the ovaries are giving up. A thing about menorrhagia is normally a woman would change 3 pads per day in a cycle. She can change up to 5 pads a day, and these two additional pads in normal cycle are probably because of hygiene. That she's very conscious of her hygiene, so she wants to change more pads. If she changes greater than 5 pads in a day, that means that she's got excessive bleeding. Otherwise, she wouldn't change them. So you've got 2 additional pads for hygiene. 3 is the standard one. Up to 5 pads a day is normal. But greater than 5 pads, she's probably got excessive bleeding. That means that she's got menorrhagia. So in this way, we can find out that, for instance, if a woman comes to you with spotting, then you'll take a history. But in the history, it's very important the timing of the history. The timing is 3 cycles. Remember, 3 cycles. Until and unless the woman has had the same period problem for at least 3 cycles, you will not further investigate that. Apart from those women in whom you suspect that they may have an underlying malignancy, you would not, for instance, if somebody comes to you with menorrhagia only in 1 cycle, you will not investigate. If she gives a history of 2 cycles, you will not investigate. If she gives a history of 3 cycles, you will not investigate. But if she comes with the 4th cycle, you will investigate. So there is 3 is an important number for any of the menstrual abnormalities. If do not investigate, if they just come with once, twice, or thrice, but in the 4th one, you will go ahead and you will investigate. So, in a nutshell, the brain, the pituitary, the ovary, and the uterus all act in synchrony to produce a normal menstrual cycle. Majority of the cases, it's an ovarian issue, it's an ovarian problem. The ovaries are failing. Second is going to be the uterine cause. Third is going to be the brain cause, and last, the least, is the pituitary cause. So there is no point in doing an FSH level. There is no point in doing an LH level, or a thyroid level if there aren't any symptoms, or a prolactin level. I often see that prolactin levels are requested for these menstrual abnormalities. Prolactin has nothing to do with that. You have to have a very high level of prolactin, a prolactinoma, to cause menstrual disturbance. So often do not investigate the pituitary gland. There is no point in doing brain scans unless there are symptoms. Otherwise, not. You can, however, do an ovarian scan and a transvaginal ultrasound scan. Thank you.